Dear friends, very good morning to all of you. I'm really very excited to share with you that we are starting a new series that is Block of the Month. We will share one block every month on our AORA Facebook page and various social media platform. And we will describe single block technique and we will try to answer uh, all your questions. So first block is PNS guided interscalene block. In recent era, ultrasound has replaced PNS at most places across globe. But in our country, India, getting ultrasound machine is really difficult, especially for freelancer. So PNS is still relevant in our country, and we should know how to give PNS guided blocks. So if we talk about PNS-guided interscalene blocks among orthopedic procedures, shoulder surgery result in the intense postoperative pain. And in recent survey, patient reported higher worst dynamic pain score after total shoulder arthroscopy, stabilization procedure, bicep tenotomy, rotator cuff repair, and acromioclavicular joint resection, then following revision arthroplasty of the hip and knee. So pain is more severe than the surgeries of hip and knee. So we need to treat this pain preemptively with interscalene block. There are various approaches with ultrasound like skirt blocks and other approaches. But with PNS, we have interscalene block to provide analgesia for this surgery. So if we look at the anatomy first, brachial plexus anatomy, all of us we know it is formed by C5, C6, C7, C8, T1 ventral roots. C5, C6 join to form superior trunk, while C7 make the middle trunk and C8, T1 make the inferior trunk. We are interested in superior trunk. It divides into anterior posterior division. Again, they form codes, that is lateral cord, posterior cord, and the medial cord. If you look at the branches, it gives various terminal branches from the cord. Uh, so you can see the branches. There are nerves from the roots, like dorsoscapular nerve and long thoracic nerve, nerve from the trunks, nerve from lateral cord, nerve from medial cord, and nerve from the posterior cord. But for shoulder surgery, we are mainly interested in branches from the trunk, that is suprascapular nerve and nerve to subclavius and axillary nerve. All of these are arising from superior trunk. So this is the main supply of the shoulder. So various block described at the level of trunks, it is interscalene block. At the level of division, it is supraclavicle block. At the level of cord, it is infraclavicle block. And at the level of terminal nerve, it is axillary nerve block. So we'll discuss about interscalene block. It is mainly for shoulder surgery. It can be used for surgical anesthesia as well as for analgesia. Even for proximal humerus surgery, we can use this block. Surgery of lateral two-third of clavicle. This is useful block along with blocking the superficial cervical plexus, because cutaneous innervation of the shoulder as well as of clavicle is by superficial cervical plexus. Uh, so if we look at this, so interscalene block is considered gold standard for shoulder surgery. If we look at the innervation of the shoulder, sensory innervation forms cervical plexus, that is C3, C4, and brachial plexus, that is C5 and C6. Main nerves for motor and sensory innervations are suprascapular nerve and axillary nerve, as I said. Minor sensory innervation from lateral pectoral nerve, musculocutaneous nerve, and the subscapular nerve. The cutaneous supply to the cap of the shoulder, upper thoracic region, and also a sensory contribution to the acromioclavicular and sternoclavicular joint is from the supraclavicular nerve, that is branch of superficial cervical plexus. And cutaneous supply distal to the glenohumeral joint is from the superior lateral cutaneous nerve of the arm, from the axillary nerve, medial cutaneous nerve of the arm, and lateral cutaneous nerve of the arm. While medial part of the axilla is supplied by intercostobrachial nerve, that is again from T2. So it is neither branch of brachial plexus nor of superficial cervical plexus. So for that, we require some local infiltration when there is incision is on the medial side. So here you can see this area is supplied by supraclavicular nerve, while remaining area is supplied by suprascapular as well as axillary. If you look at the joint supply, mainly it is by suprascapular nerve and axillary nerve, while some of the component is supplied by lateral pectoral nerve. So if we look after indication, if you look at the contraindication, if patient refusal is there, we should avoid it. Local infection and allergy to LH are absolute contraindication. And there are some relative contraindication, like if patient has COPD or contralthrenic or recurrent laryngeal nerve palsy, we should avoid it because it may worsen the things by phrenic nerve palsy and the recurrent nerve palsy of the same side. So if we look at the landmarks first, we have to draw the landmark. First important landmark is we have to draw the sternocleidomastoid, both head. This is the sternal head of the sternocleidomastoid and this is the clavicular head of the sternocleidomastoid. This is the interscalene groove. So how to palpate, we will see in the further slides. And this is the EJV. So EJV is closely related to interscalene groove. And we have to go at the level of C6 level, that is cricoid cartilage level. We have to go just below it for a lower interscalene block, while conventional venous approach, it is at the level of cricoid cartilage. So if you palpate the landmark in thin and lean patient, here you can see this is the sternal head of the sternocleidomastoid. If we ask the patient to lift the head, we will see the clavicular head. So this is the clavicular head of the sternocleidomastoid. We put the finger posterior to it and we will palpate the uh, anti-scalene muscle, and then we can palpate the interscalene groove. We can see EJV is closely related to interscalene groove, so it is just anterior to the EJV. So once we palpate that groove, we will mark the cricoid cartilage and we will draw a line from the cricoid cartilage. So this is the cricoid cartilage I'm marking, and I'm going laterally at the level of interscalene groove. We go just below it and we direct the needle a little bit of caudally and at the perpendicular angle. So this is in thin and lean patient, easy to palpate. But this is a fairly built patient. This is basically a volunteer where I mark the things. So here you can see this is the sternal head of the sternocleidomastoid. This is the clavicular head of the sternocleidomastoid. The sternal head is easy to palpate, but for clavicular head, we should ask the patient to lift the head. You will see how lifting head will help. So now you can palpate both. Now I will put finger posterior to the clavicular head of the sternocleidomastoid, go 1 to 2 centimeter laterally, and I will feel the interscalene groove. If I'm not sure, I will ask the patient to snip, and it will make the muscles, scalene muscle prominent, and I can easily palpate the interscalene. I have asked the patient to snip, and I can easily feel the interscalene glue. Once I get it, I will mark it, and I'll draw the level of cricoid cartilage, and I will draw the line again, and that is the point where I will insert the needle. Here you can see I palpate the cricoid cartilage and going parallel to it the level of interscalene groove, and here will be my entry point. I'll go perpendicular to the skin just below it, and I will try to elicit the response. Now we will see how to elicit what are the various responses and how to elicit it. Initially, when you put your needle, if you are too medially on the sternocleidomastoid, what you see is the local contraction. This is not desirable response. You are too medial, you have to go a little posterior and look for the response of the either deltoid pectoral muscles or and the biceps muscles. So this is not desirable response. Again, this is in the another volunteer. You can see the local muscle contraction when it is on the sternocleidomastoid muscle. It is not a desirable response. When you are on the phrenic nerve, you will see there will be a contraction of the abdominal muscle. Here you can see this is the contraction of the diaphragm. That is because of the stimulation of the phrenic nerve. You are too medial and anterior. You should go posterior and lateral and reinsert the needle to look for the response. Again, yeah, this is in the thin and lean patient. I'm on the phrenic now. I'm stimulating with the stimulating pen, and you can see the phrenic nerve contraction. That is the contraction of diaphragm. This is not desirable response. So what else? sometimes when you are too posterior, you will stimulate the accessory nerve that will cause the contraction of the trapezius muscle. Again, this is not desirable response. I will not accept this response. Desirable response is the response of the pectoral muscles, deltoid muscle, or biceps or tricep muscle. So this is the this is the ideal response where you will see the contraction of the biceps muscle or triceps muscle. This is a good response, and I will start with 1 milliamp current, and I will reduce to point, zero point 0.5 milliamp. I will go up to zero point 0.2 milliamp. If I'm getting the response at zero point 0.2 milliamp, there are chances that I'm in the vesicle. So I will withdraw the needle and then try to get the response at zero point 0.3 to zero point 0.5 milliamp, and then I will inject 15 to 20 ml of LA. So again, here you can see the ideal response contraction of the biceps muscle. I will accept this response. So this is in a patient where we give interscalene block along with GA. You can see I marked the both the head of sternocleidomastoid. I'm posterior to it. I'm looking for the biceps contraction, and you can see the bicep contraction. I start the current with 1 or 1.2, then I will reduce the current up to 0.5 milliamp and look for the response. And if I getting the response, I can inject 15 to 20 ml of 0.2% ropivacaine. If it is for analgesia, I will inject 0.5% ropivacaine 20 ml if it is for surgical anesthesia. But when it is for surgical anesthesia, you have to supplement it with superficial cervical plexus block. That is just cutaneous innervation posterior to the uh, um, clavicular head of the sternocleidomastoid, and it will block the superficial cervical plexus. So that is how you can do it. That is very easy, and you can get the block very easily. So this is how you can do the interscalene block with PNS. It is a very superficial block. You get the response roughly at 1 to 2 milliamps. If you are not getting it, don't go too deep. Relocate the needle, remark the landmark, and try to elicit the proper response. If you are too medially, there are chances you puncture the carotid or IJV, and there will be a aspiration on the blood. So in that case, you have to go posteriorly. So this is how you can do troubleshooting various. You can understand about various responses and why it is happening, and give the block. Drugs, as I said, you can use 0.5% ropivacaine or bupivacaine for surgical anesthesia, 15 to 20 ml. If you want to use it for analgesia only, then you require ropivacaine 0.2% or bupivacaine or levobupivacaine 0.25%. Again, it is 15 to 20 ml of LA. There are certain side effects like if you there are chances that drug will spread to recurrent laryngeal nerve and it will cause hoarseness of voice. Sometimes there will be Horner syndrome, that is because of sympathetic cervical ganglion chain block. Patient will have Horner symptoms like Horner syndrome, just like a stellate ganglion block. Patient may have hemidiaphragmatic palsy because of phrenic nerve, but it is not an issue with normal lungs. If patient has COPD or contralateral side phrenic nerve palsy, then it can cause problems. So you have to be careful in such patients. Just reassurance and some oxygen is required most of the times. Complications, sometimes it can cause infection, hematoma. There are reports of total spinal anesthesia when you are too medial and you inject the drug in the dural sleeve. So never inject below zero point 0.3 milliamps, as I said, and high injection pressure, because you might be in the dural sleeve and you inject the drug in the spinal subarachnoid space, and you can cause total spinal anesthesia and even cardiac arrest. There are reports of no injury with um, interscalene block than any other upper limb block, because at this level there is more of neural tissue and less of connective tissue. So if you go intraneural, you can injure the nerve. Local anesthetic systemic toxicity, you have to aspirate before inject. This is a vascular area, so always be careful. Always inject in small aliquots. Keep talking to the patient. Even after giving the block, never leave the patient alone, because last can happen even after 1 hour. So be careful about it. Some rare alerts: never give bilateral block, as we discussed, to avoid bilateral diaphragmatic paralysis, which can lead to patient respiratory distress and sometimes require ventilation also. Never inject if you find resistance on injection to prevent nerve injury and total spinal. This is very important. If you are, you should inject the drug yourself. Don't ask your assistant to inject, or else you can ask your colleague to inject because they don't know about the pressure during feeling of the pressure or resistance during injection. So always you can use pressure monitoring device. If it is more than 15 psi, you should be careful, but it is not available everywhere. And last but not least, intralipid is must. It should be available in every OT where you are performing the block, because local anesthetic systemic toxicity can happen everywhere, and only intralipid can save you if you are using bupivacaine. Some pulse, look for response of the deltoid, triceps, and biceps. That is the desirable response. You can inject with response of pectoral contraction, but success rate is lower. Finger response is not desirable. You can consider it in the lower interscalene block, but it is a good response for supraclavicular block rather than interscalene block. Combined with superficial cervical plexus block for clavicle surgery and even for shoulder surgery to provide complete analgesia, and lower trunk will be spared in the most of the cases if you are using 15 to 20 ml. So you cannot use this block in the elbow surgery or below elbow surgery. So be careful about it. So this is all about it. Thank you very much.